Good morning. This is Dr. David Nace, Chief Medical Officer with Innovaccer. Welcome to Connecting the Dots Data Activation for High-Intensity Care Delivery at CHI Health Partners. This is Dr. David Nace, and we're really pleased to welcome you here today. I'll be moderating this conference, and I'd like to next move on to introducing our panelists. So today, I'll be moderating throughout, and joining me is Dr. Paul Grundy, Chief Transformation Officer here at Innovaccer, and also the founding president of the Patient-Centered Primary Care Collaborative. Paul, welcome. Also joining us is Ann Oasen, who's president of CHI Health Partners. Ann, pleased to have you here.
I'm excited to be here. Thank you.
Great to have you. And joining her is Dr. Henry Sikowski, who's the Network Medical Director, also at CHI Health Partners. Hank, thanks for joining us.
Thank you.
Awesome. So with no further ado, let's get started. So one of the reasons that CHI Health Partners has been chosen for this particular webinar on advanced clinically integrated care and the use of care management is they've really been a pioneer in clinically integrated care. And tell us a little bit about CHI Health Partners and how you ended up on this journey of value-based care.
Okay, we actually, as you can see there, we're based in Nebraska and Southwest Iowa. We started as a clinically integrated PHO in 1998 and have just continued to grow. We had about 800 providers at that time. And now you can see that we're over 3,600 providers and over 36 hospitals, 17 skilled facilities. It's a very large clinically integrated network. All of our managed care contracts run through this organization. We've built an infrastructure to help support the value-based contracts. We're receiving approximately $8 million in care coordination fees from our managed care payers, and able to distribute bonus money for our performance in 2017. So it's been really a great journey. Our leadership within CHI Health believes very strongly in value-based care. And so having CHI Health Partners and this clinically integrated network fits in really well with everything we're trying to do.
That's awesome. You know, Dr. Sikowski, you've been kind of approaching all this from a clinical perspective, and you've got quite a long track record there to build upon, plus really a big enterprise that you've been building this on. Tell us a little bit about your perspective on what care delivery in value-based care is all about.
Well, like Ann said, we've been around since 1998. And we actually, our oldest risk-based contract started in 1999. And back then we were really kind of flying blindly in trying to manage that population. We really didn't have anything but, maybe quarterly payer performance reports to go by, and it was really really not very actionable or timely. And so a lot of our performance was probably more luck than anything at that point. But over the last 5 or 6 years, we've gotten more data. We started to look at claims data, and that just made us hungry for more. Trying to get claims data and clinical data aggregated and really give us a more timely view of our population and what their needs were. I think really, the keys for us is twofold. Really being able to give providers information on how they're performing and what the opportunities are, and then really identifying the needs of the population and identifying those folks who are high risk and those folks who need extra care and coordination because they're having acute health issues, and really being able to identify and in real time and manage those populations were going to be the key to us being successful.
No, that makes a lot of sense. And I have to tell you, it's so impressive. I mean, you guys have been working at this for, I think, longer than anybody else I've met in the country. And so you've got this tremendous experience, this vast network that you've built upon. So there's so much we can learn from you. Dr. Grundy, I'm so pleased to have you here as well, because you've been a real pioneer around the whole purpose of primary care at the foundation of this and the role of care coordination. Tell us about your experience from all those years being president of the Patient-Centered Primary Care Collaborative.
So the journey that we've been on, and this came as a drive from employers to get at better value, is really a journey of moving away from paying for episodes of care to being able to get at the data to proactively manage a population with that data. The covenant change that has happened over those years, and the principles that organized primary care agreed on, was really creating a system integrator, a place in the delivery system which makes sense it should be in primary care, that is really the experts in managing a population. So the covenant change is away from I'll show up when I'm sick to I will be managed by a primary care trusted healer who has the data, who understands how to interact with me and manage. And one of the systems that stepped into this really early on was the Veterans Administration with their patient-aligned care teams, and they did a huge study. They have about 10 million lives, and they did a huge study looking at the impact of the various elements of that primary care based delivery system as a system integrator. And this slide demonstrates that coordinating care actually had the greatest impact in quality, followed by access and continuity. And I'm just curious what's the experience of CHI in this journey compared to the Veterans Administration.
Yeah, that makes a lot of sense. And this concept of care management and care coordination are so important, and this slide so much speaks to that with such great experience from the VA. We are talking about, as an industry, moving away from fee-for-service and paying for something else. And Dr. Sikowski, I'd like you both to comment respectively on what we'd be paying for if we weren't paying for each service at a time.
Right. So we're living in both worlds right now. We're still in the fee-for-service, but really trying to keep people out of the hospital, keep them out of the ERs. And so it's difficult, but I'm really excited about the new CMS announcement that came out this week, because I think once CMS does something, a lot of others follow along when you have the big dog that's going to lead this. So we're very excited to see that change, although we don't know all the rules around it, but we'll definitely be signing up for that.
And I think historically, we in the healthcare field, we really provide sick care, and that's that I think the system in the fee-for-service world was really set up for that. We kind of sat on the sidelines till somebody got sick, and then we'd come in and try and fix things. And now, I think with population health and value-based care, we're really getting back to healthcare and trying to figure out how to keep our populations healthy. And that includes all. That means, the healthy people, keeping them healthy, the folks with chronic conditions, helping them manage their condition optimally to keep them as healthy as we can for them and keep them out of our ERs and out of our hospitals, which historically have been where we've done most of our care. It's the last place we want to do care now in a value-based world.
That makes a lot of sense. So it really sounds like you're not paying for just delivering individual services, but paying for actual outcomes, as well as being able to do the right thing, or what we often call process measures, and then also keeping patients more as consumers satisfied and happy with the service, access, etc. So great points. We're going to really get into how you did that at CHI Health Partners. But first, let's ask our audience kind of what their biggest challenges are in succeeding in value-based care and delivery payment models. So if we could bring up the poll, there are 3 choices for each of you. Please feel free to identify the choice or choices that make sense to you. Select one of the following. Doctors lack the time and insights to fully engage with patients. We hear a lot about people who are constantly typing and have their backs to the patients. Is that an issue for you? Second choice is you can identify high-risk rising patients, those that will be at risk in the future, not behind in the retrospective for last year, and also being able to close care gaps. What care gaps do we need to close? What are they? I'm too busy seeing patients one at a time. And then lastly, do we not have the technology to support automation and care management? While we're waiting for the poll to close here, Hank or Ann, if either of you could just comment around these key issues, were these things that you had to address in your journey?
We were just commenting with all of them. You know, I think it's hard to just pick one because it's so important, each one of those. And I've heard Hank can talk more about this, but you know, there's so many things that the primary care physicians have to do in a day that I think it's every one of those.
That makes a lot of sense. Hank, do you agree?
I agree. I'm a primary care provider, so I mean I'm very empathetic to the lack of time in a doctor's day and all the things that need to be done, and including, you know, trying to remember the patients, not just the ones in front of you, but the ones that aren't in front of you that need care, and really having no insight into what's going on with my population of patients if they're not right in front of me. So you know, all 3 of those things I think we're going to be key to us being successful.
Awesome. Well, let's see what our audience thinks. Do we have the poll results in? I believe we are about closed. Okay, here we are. Interestingly, doctors lacking the time and insights being number 1, and then the other 2 being just behind. I'm going to ask, I know, Paul, to start off here. Did these results surprise you?
Absolutely not. And I guess my experience in visiting practice after practice quite literally broke my heart. It was so sad to see primary care doctors spending only about a third of their time in doing what we would want them to do, and that is difficult diagnostic dilemmas and relationships. You know, they were spending way too much time with their EMR and with the computers and getting at stuff that they shouldn't have to do. You know, I think supporting them with the technology to take that burden off of them and allowing them to practice the top of their license is going to make a huge difference in how care is delivered.
That makes sense. Ann and Dr. Sikowski, you know, when you look at your experience, was this the most important thing to address, and have you been able to make headway in resolving this challenge?
Well, I think one of the keys was really giving doctors the information and the ability to engage with their patient population, and then building, you know, a team around the doctor to really make it happen, because, you know, the doctor is still going to be in clinic seeing patients, but he or she really needs a team, and then that team needs to have you know, reliable data to really manage the population that doctor is responsible for.
Yeah, they need the information. And how about you? You've been overseeing this whole group achieving results. How have you seen the doctors engage with patients better, or what's been the secret sauce you've had to achieving?
I have, and one of the things that we did at CHI Health Partners was to embed our population health coaches within the primary care office, but we employed them, so then they couldn't end up, you know, Susie's not here today, so can you, population health coach, act as my nurse and round patients? So I think that that's been very valuable. It's been a great resource for the physicians that they have someone they can hand off these chronic patients to that then can work with them to make sure they're getting all the resources they need.
No, that makes a lot of sense. And, you know, I've heard this model of embedding the health coaches into the practice being so successful. I think they become part of the team then, huh?
They do. They do.
Yeah, that's really awesome. And, you know, I know, Dr. Grundy, you've actually gone around the country over the past decade talking to folks. I think this issue of team-based care seems to be really important.
it's really a team sport. And when it's done effectively, those gaps in care are by and large handled up front and don't show up, at the time when the doc really needs to be spending time building relationship with the patient and sorting out what they need to do with difficult diagnostic dilemmas.
Awesome. So let's move on and talk a little bit more about CHI Health Partners and some of the key ingredients and how you achieved it. I think, sorry about the backtrack there. Just a reminder for everybody that we're going to have questions at the end of the webinar. Please put them in the text box, and I'll be watching them as they come in, and we'll get to those at the end. So when we look at CHI Health Partners and delivering this sort of value-based care across this enterprise, how did you get to this scope, this number of attributed lives and number of payer contracts? How did you go about getting to this, and how did you manage such a scale?
So as I said, we've been around since 1998, so it's been a long journey. But as we built our infrastructure, which is very expensive when you look, there are 75 health coaches that we have embedded out into our clinics. It's really around, we needed to move away from getting paid for everything that we did into value-based care. As we're working and we keep people out of the hospital and keep people out of the ERs, well, we are a health system. I mean, we have hospitals in our CIN as well as physicians and advanced practice clinicians. So it's important that we're replacing that revenue some way. So that's why we moved to all of these value-based contracts. Everyone except one of our contracts has some type of value-based, either shared savings or shared risk or a care coordination fee that we're able then to help support our infrastructure. The attributed lives, it's probably now about 250,000 lives. So we just keep adding to that and looking for that growth.
Well, that's quite substantial. I remember I was head of one of the largest ACOs in the country, and we were about 150. So you've got quite a large scope in front of you. Dr. Sikowski, standardized care plans. Doctors hate what they call cookbook medicine. How did you get doctors on board to going to a more standardized approach with the rest of the team?
Well, I think one of the keys was, like Ann mentioned, is that we need to really move all our contracts to value-based. It didn't make sense to ask docs to practice one way for one population and another way for another population, and they really needed to really understand that we were moving all in on value-based contracts, and then they really needed to understand what that meant, and part of the key was, value was really about, quality first and foremost. High quality care should hopefully be efficient care, and one of the keys to high quality care is that it's evidence-based, and still taking in individual patients' needs. And there's some there are guidelines, there are things we can use to hopefully standardize care about, and then having a system to really provide docs information on their performance so they can see how they're performing compared to the standards and how they're performing compared to the network in general. Docs in general are competitive, so all you have to do is put some information on performance in front of them, and you'll get the results you want.
That makes a lot of sense. I keep hearing this word system and having the access to the information. Anne, as you began your journey around thinking about how you develop a system that supports some of that, what was your journey in picking technology and its value around coordinating and collaboration amongst the team? So
we started really building the infrastructure about 2010. We were doing discharge follow-up and found a lot of things around medication errors and things that when patients were leaving the hospital. And we had a tool at that time and started to feed claims data into it, but we could never get the clinical. And so we decided about a year ago that there was technology out there that would take the claims data from the managed care payers, and it would take the clinical data and care coordination and combine them all into one tool. So we were really excited about that. We thought that's where that would get us to where we needed to be to really manage these lives, to see those gaps in care. And so we moved ahead with this different tool that would allow us to pull all that data in. I will say that data is really difficult. It's been difficult to get data in the past, so we're very excited as we can pull all of it into one tool.
And it sounds like making that data useful for the various players, the health coaches, the doctors, maybe even the patients. Hank, once you have the data, how do people find it useful?
Well, the key is making sure that the data is valid and reliable, and then and realizing that nothing's perfect, but you start to share this information with docs in a non-threatening manner, let them react to it, and tell them, show them that the goal of all this reporting and showing them performance is to improve performance, and that's it. And it's pretty easy to do. I was just thinking of an example. We put out reports on how we're doing with our HCC coding for our Medicare ACO, and so we put out reports by clinic, and I was sharing the report to my partners in my clinic, and one of our docs was her score was rather low, and she goes, "What is this?" And you could tell she hadn't really engaged much in it prior, and I kind of explained what it was showing, and we started looking at some of her patients, and she probably had the sickest population of patients in our clinic, and within a couple of months we ran the reports again, and I just sent them out last week, and she's at the top of our clinic where we thought she'd be. And it's again, all it took was one time showing her where she was compared to her peers in the clinic, and she took it to heart. She looked at the education materials that we provided, and she did what she needed to do. So it's just getting that information, getting valid information in front of the docs that's useful, and then letting them do what they naturally do.
Now, that's a great story of success too, and it really shows the power of showing the information to the physician specifically about their patient and specifically about their population. Dr. Grundy, at Innovaccer, we were so pleased that CHI Health Partners chose Innovaccer a year and a half ago to pull together this clinical and claims data and provide these kind of insights. I understand that we call this the data activation platform. Why do we call it that?
Because, this is going to do for the doctor's minds what x-rays and images have done for their vision. It's going to make it clear what you need to do for a patient, allowing a plan for each patient that's pretty sophisticated, but right in front of their eyes, and making it clear what you need to do. I mean, in talking to folks like CHI and some of our other clients, I mean, this takes 4.2 minutes of time away from the computer and gives you the information you want to need. And as a team-based sport, many of these gaps in care, many of these issues that you see here on this slide get eliminated by the front-end staff. And so that allows the docs to really spend the time in the relationship with trust. So a 360 view of really understanding what's happening with the patient. That's information coming from the EMR, from the social determinants of health, from the communities they live in, from claims, from laboratory, and just giving them a clear picture right at the point of care without toggling, to see what they need to do next with their patient and how they need to follow up and follow through, proactively managing that population.
No, that makes a lot of sense. And, Anne and Dr. Sikowski did a wonderful job of showing us how such an activated data platform really allows them to scale their care management system We've got all these care coordinators, health coaches embedded in the practices. They're all having access to the same information. And then they also, Hank, you talked about standardizing protocols and getting some workflows in place. Tell me, when you do that, it's not just about technology. So once you get technology in place, how do you deal with the workforce and getting them to both adopt it and move forward with doing things differently? Hank, maybe you could speak to that.
Well, most of these care protocols are being used by our health coaches in kind of managing and coordinating care for chronic conditions. So, and they actually helped. They worked with the team at Innovaccer to create their care management platform and these protocols. So you got automatic buy-in because they were able to help create it and produce a system that was efficient for them and really met their needs. So buy-in was pretty easy because they helped, their input was utilized in creating them, and they see the value in being able to, to let the system kind of help them, guide them in managing these patients over time to make sure that they're addressing all the key topics and the key quality metrics and things that are important for that management of that chronic condition going forward.
That's right. And it's not just the teams, right? You have to manage the overall population and the contracts. And how is this sort of integrated data platform being activated? How has that helped you manage these contracts and the overall workforce and population health management in general?
Well, one thing that comes to mind for me is we have all of our contracts have quality metrics built into them that we need to meet. And the only data we had on meeting those quality metrics was from the payers. So we had to just go with whatever the payer said, yes, you haven't met this quality metric, but we didn't really have data to go back and say, yes, we did. And now we have that data. So we can go back and we can run our report and compare it with what the payer may say or the carrier may say and say, really, here is the data we had, and these are the patients that we have that data, and yes, we did meet those quality metrics. So there's some real value in that for us as we're working on these value-based contracts, because many of those are either light switches to shared savings, or it would affect any kind of shared savings that we would get. So it's nice to have the report that we can then utilize to help us close those gaps, but then also to compare with what a payer has.
No, that makes a lot of sense. And, I think you've both demonstrated how clinical leaders also require this insight too. And also, I think Hank, you pointed out very nicely that people want to see how well they're doing as an individual performer, certainly both not only the care coordinators like we see here, but also I think in terms of the doctors and being competitive and wanting to be performing with the group, if not being a star. So I think all of these things pull together, as Anne's, kind of elucidated, that once you have the dashboards, the reports, you can manage the contracts, and everybody needs a clear view to succeed as a team. That makes a lot of sense. So let's move on and take another poll from our audience to say, geez, if you're thinking about purchasing, where are your priorities about enhancing your care management processes? As you begin to evolve and the landscape, as it's been pointed out, CMS is trying to move everybody to risk. What are you thinking about in terms of what you're going to buy next? What are your purchases going to be? How do you need to evolve that system? Is it a modern platform to activate your data? Is it using more automation around the care management solution? Is it using analytics to generate actionable insights? Is it a robust patient engagement application, such as a handheld on a smartphone? Or do you currently not have any plans? You think you're good? And on this one, I think you can choose multiple choices. Nope, select one or more, so multiple choices. Feel free to pick any one of these. So while the audience is picking this, Paul, and Hank, you want to comment on which of these things seem to be the most important in your mind before you made the decision you did?
Well, I think in our group, it depends on who you were talking to. Obviously our health coaches really thought, having a platform to really allow them to manage their populations was going to be key, and have it automated and really meet their needs. Claims information, a platform that handled claims really gave us a 360 view, because it would show what's going on regardless of where the patient received care. But it was old data, clinical data, more actionable. It gives you a better look at quality outcomes. And then patient engagement, key to really getting the patient to do what they needed to do at the right time in the right place. So again, they all kind of are important, and depends on who you're talking to in our organization.
And
I agree with Hank. I think he covered it well.
awesome. Then you guys make a great team. We like when we see team alignment. So I think we've got great results coming in. Why don't we go ahead and open the poll and see what the audience thinks? Well, this is interesting. Number one is having analytics to generate actionable insights. And everything else falls kind of just behind that. And then there's a smaller group of people who think they're just fine and dandy. So Hank?
Yeah, and again, I think they're all, the four were pretty, actual insights analytics is number one, but all four of them were important, I think, to most people, it looks like.
Yeah, and I think, we see that getting analytics in place with a platform seems to be just behind it. And who knows, maybe having no particular plans mean they've already made enough purchases where they could be Innovaccer's clients. I'm not sure. So with that, we'll just move along and go on to the next section of our presentation. So we talked a lot when we introduced, and it's really in the title of this presentation, about not just care coordination or care management, but high-intensity care delivery, right? How do you really adopt an advanced data-driven approach? So you've made your decision to take technology, you've got claims and clinical data now together. Where do you see yourself today in terms of what you're dealing with? You've got this technology in place, you're getting more success. What are you working on today? What are the problems you're trying to solve today?
So one thing, and this is once again from the business side, so we've moved into some narrow networks, narrow value-based networks that are just around the providers that are part of CHI Health Partners. And so it's important for us to go in and see what kind of keepage we have and where are patients going. If they're not getting the care within our own CIN, where are they going and why are they going? Do we have gaps that we need to go back and fill? Or is there another reason that that care is not being given into our network? And so having that data that we can drill down to the physician, down to the patient, has been very helpful.
Well, down to the patient or down to the individual physician, man, you've got 36 hospital systems. That is a lot. So with such a vast enterprise, how can you go zooming in and out of that kind of data? Like, how do you manage that in terms of the teams that are managing at different levels?
Well, I think the key is really in population health. You're really got to focus your attention on the impactable high risk, and you've got to be able to know who those are. It's the 80-20 rule, where 80% of the spend is by that top 20% of the high risk population, and really identifying who those folks are and who's going to become those folks is key. So you can put we all have fairly limited resources, and really making sure that those resources are being used optimally to manage the folks that need those resources the most. And so we really needed to be able to understand who is high risk, and the insurers would give us reports, but their high risk was based on historic spend. So you may have a patient who had a trauma or some big event and it's over, and now 6 months down the road we find out about it from them that, oh, here's a high risk member. Well, it's come and gone, And you really need a system that's going to tell you, who's high risk now, and even more importantly, who's going to be high risk next year.
So it really is about managing these different contracts and thinking about who's going to be risk, particularly financial. Were you able to have that information before you had the claims files integrated, and how has integrating the claims and clinical helped you, Ann?
No, we did not. And it's going to help as we look at the different payer results and being able to compare, really, as we go back and renegotiate those contracts. Having that information is very valuable. If we can see, how they're paying us, or how we've performed on those contracts, it helps us as we negotiate our value-based contracts with them. And having that data then to show them is also very helpful.
No, that's really great. Hank, can you think of a story you could share about where bringing this financial and clinical data was really helpful to one of the practices or one of the physicians or teams that were working on this?
Let's see. We, I mean, there's really it's an everyday thing. I mean, in my practice, we have a health coach, and she gets the list of folks that are identified as high risk, and just runs those by us, and it really all of a sudden my population is narrowed down. Here's 20 or 30 folks for this contract that are identified as high risk. A quick conversation with her, and I can say, here are the issues that are really impacting these folks. So she has information. Working with me, I have information, and then I can really have her focus on the folks that really need her coordination of care over time. Some folks who have social determinants of health that may impact their ability to get in and see me on a timely basis, or be able to get the care they need. And if we can identify those, we have some resources. We can put those resources, to good use and really be impactable.
That makes a lot of sense. So, Ann, this concept of managing different contracts, right? This is complicated, I would imagine. So we're just picking a make-believe example of a slide here. So these aren't real numbers or the real payers they're associated with, but we wanted to show you what the demonstration of what the kind of platform you're looking at is. How has this been helpful to be able to see different payers, different contracts, and how you're performing? How do you actually execute on that?
So this is great that we can share this information with our board and with we have what we call a clinically integrated network council of physician leaders. So we can share this data and see how we're performing. If we're performing, let's look at payer 2. Our saving potential is really good there. What can we do about payer 1? Or there's some things that we can learn. The other thing is, unfortunately, all of our contracts don't have the same quality metrics. It'd be really nice if the payers would all agree and we'd have, 7 quality metrics that we all worked on. So by having this data here, it also helps us keep our eyes on, okay, yes, this is a quality metric that maybe Blue Cross has, and this is a quality metric that Aetna has. So it helps us keep track of that as well. And then know if so maybe our ER visits are up. Is there something we need to focus on? So it really helps us as business leaders looking at the data to figure out what we need to adjust.
So it sounds like you've got a team put together that looks at this from all different viewpoints. What do you do, like when, say, you're performing well, you have in one contract, but there's one particular pain point, but it's a very different pain point in a different contract? How do you deal with that in terms of the population in your teams?
Well, if we're performing well in one contract, we celebrate, first of all. And then, and then we go back to determine if there's something, because as Dr. Sikowski talked about earlier, they're not really, physicians aren't looking at the payers when they're treating patients. They're treating everyone the same, right? So is there, if we're, let's say, out of network or visits are up in one, so do we have gaps somewhere? Is there something that's missing in that we're not, maybe we don't have the right physicians in, or we need a specialty that's not in with that payer? So we're just going back and looking at the data. And one thing about data, once you show it, you want to drill into it and drill into it and drill into it. And that's what we would do, is try and drill down to see what's causing the difference.
No, that's amazing. So, I'm actually seeing the questions as they come in. I was going to wait for them to wait till the end, but there are a couple that relate here. So a lot of this financial data around contract performance, et cetera, this really depends on the kind of lag you're getting in terms of getting that claims information, getting the performance in a timely way to your group to make decisions. Like if you have a SNF problem with SNF referrals, or a particular, network people are costing you more money, and you didn't know that before. What's your claims data lag? Has it changed since you've moved to the new technology? How's that going for you now? Do you have a sense of what that lag is?
Well, I know that as far as getting the data into the tool, that's much better than the previous tool, because sometimes it would take a year before we'd ever get the claims data in. So that's coming in. There's always that drop off, and that's the problem with claims data, is it's usually 3 months before you're settling, or 3 months it's in arrears. So it's a struggle. Pharmacy data is always much better than the medical data, but I think getting it into the tool is much faster. It's just still, and that's why it's nice to have the clinical tied with it as well, especially looking at gaps in care.
Yep, so it sounds like you're dependent on the payer to get you that issue and that lag to come in based on when those claims are submitted. But then once you get it, you're able to get it right into the system now.
Right.
Awesome. Okay. Yeah, a year is an awful long time to wait, for sure. So this is really exciting and really makes a difference in your population performance, for sure. Let's go back to the audience, because this issue of integrating clinical and claims data keeps coming up. Let's ask the audience here, which of the following data issues does your organization struggle with? Is it exactly what we were just talking about, being able to bring the clinical and claims data together? Is it not having a consolidated 360-degree view across your network, or your healthcare system, or your population health entity? Or is it really the lack of having advanced tools in order to have a truly predictive analytics, truly be able to predict where your risk and where your clinical gaps are? If we can pull this poll up and get it going, you can select any of the following, one or more, so we get a full view, because some people may need all three of these. So I'm going to go back to 2 years ago as you made this decision and began to move ahead. Ann and Hank, which of these three seem to be the most important to you, and which would you see as secondary that you were trying to tackle and then were able to tackle?
Well, I think the first one, at least when I look at it, because we couldn't get we couldn't combine the clinical. We had the claims in some cases, but we couldn't get the clinical in there, so we couldn't see those gaps that we were missing. And then I think the other one, for me at least, is the predictive analysis. Which patients should we be working with? As Hank said, we just have limited resources, even though we have 75 nurses embedded. But it's still, we need to focus on which patients will get the most value out of the care that we're providing.
How about you, Hank?
Well, I'd agree with Ann. The unable to combine clinical and claims data. We had just difficulty getting claims data in. I mean, it took forever. Unfortunately, every payer has a different way of delivering their claims data. They all have different headers, different methodologies, and the previous system we had, had one way of ingesting data. So we had data guys that would spend hours and hours trying to get the different payer data into the format that our system would accept, and it was hugely frustrating. And now we've got a system that'll take that'll take claims in almost any format and will ingest it, and that was a huge advancement, and then getting EMR, our major EMRs hooked up was the second one.
Yep, no, that makes a lot of sense. Getting your EHRs together, all the clinical data, getting the claims information in there, and then being able to use that to put valuable insights in front of your teams. Nope, that makes a lot of sense. Well, let's take a look and see what our audience says. I believe we have the results done. Here we are. Interesting. So what do the two of you make of this?
Looks like they voted with me. Yeah, no, I think that I agree. They're all important, but I just think being able to predict the patients is really important.
Yeah,
Go ahead.
The healthy patient who is doing everything right is someone you don't need to focus a lot of time on. But there are folks really struggling out there, and because of healthcare issues, but also because of social issues, and again, not being able to know what's going on outside the doctor's office leaves you really vulnerable. And so really, having a system that will tell you, no, this is the patient you really need to work with, and getting upstream before they've had a major health issue, that's going to be the key to success in value-based care, I think.
No, that makes a lot of sense. So you brought up a really important point, which is what about the social issues, and what about information beyond the claims and clinical data? So let's start talking about looking forward and what you're trying to tackle today. Are you looking at additional sources of data? Are you seeing importance in pulling in other forms of data like social data or other forms in terms of bringing into the platform and using to give your teams insights?
Well, we have, as part of the care management platform that our health coaches helped create, they've embedded a fairly brief survey that for every patient they work with, it kind of helps identify some social issues. Innovaccer is just introducing, I just met with them this morning, in fact, a social health predictor using, he said, 54 different metrics and really guided by zip codes. But and they've done some analytics and shown that it helps predict ED utilization. So we're excited to work with them on that and see how that will allow us to stratify our population even further.
Yeah, that makes sense. Anne?
I don't really have anything to add.
Oh, well, you've had a long career, over the time, building out this system and building these teams, and just, interested, we've got a lot of interest on the Hill talking about social determinants of health, social determinants of health and where that's going. Where do you see the future in terms of that, in terms of driving, pulling together traditional clinical care with what's always been in the shadows, really, what occurs in the community around social care?
So we're a couple of things that we're doing, we're just going to start to do. We think that there's some real value in that. Is we haven't consistently done the annual wellness visits. So I think bringing patients in and doing annual wellness visits, social determinants of health, to me, it's always been a problem. It's just now that it's got a new name, it seems like. That, these people have had social problems. And in our network, we have social workers who are we have a couple that are embedded in our clinics, but also some that are more centrally located that can support all of our clinics. And there's such a need for that. I think having that data, being able to figure out what we can do. We are starting with one of our payers a food program where we're looking at diabetics. So we're going to do a pilot around diabetics and getting them education on food, getting them education on cooking, having them take cooking classes. So we're very excited about different projects like this. And we'll be able to have a baseline data and then see, by having this data, see what success or what outcome we'll have.
No, that makes a lot of sense. And, as we look toward the future, you have to think about how do you keep patients happy? How do you keep them engaged, right? And it's not just when they come in for their doctor visits, it's round the clock. Let me ask Dr. Grundy, because he's been listening to this and wondering, Paul, how do you see the future around how connected data and bringing together more forms than traditional clinical and claims data may help engage people and keep them more satisfied with what they consider to be good healthcare?
Well, thank goodness that we've moved out of the information age into the age of intelligence, because I think that's going to be necessary to really understand and automate the process of engaging people below the tip of that iceberg, right, where you're dealing with the sickest few, to an automated system of reminding people when they need their immunizations, when they need their breast screening, et cetera, and getting much better at following up and following through with a consistent, stable plan for each patient. That's going to make a huge difference. I mean, we know. I mean, the guy that won the Nobel Prize last year was for behavioral economics. I mean, we know what we can do to stimulate people behavior, and we need to engage in that.
Yep, that makes a lot of sense. So I'm going to just, before we go to taking questions, kind of just summarize. I'm hearing that this sort of moving into the age of intelligence really can help us really continue to engage physicians at the point of care, maybe reduce the time they're spending pecking away in the computer, spend more time with patients. And then I think you mentioned deploying a mobile app, or in addition to getting some kind of a survey tool, might really maybe help to keep people connected around the clock, not just when they come into their doctor's visit. So these are wonderful ideas, and I think as we move into more telehealth capabilities, telehealth via your smartphone, asynchronous communication, all different ways to communicate and keep people healthy around the clock. I have to say, I was just here in Boston today and was in a meeting earlier where they were showing how giving the patient data about their own performance as we get into things like wearables, that begins to activate them, and they begin to say, oh my gosh, I had no idea that if I eat popcorn in the morning that my sugar spikes. Maybe I should stop eating popcorn. So there's all different things that this concept of a data platform can really help us with. But let's go on and move into asking some questions here. So I'm going to start off here with the first question we got out of the box today, which is, Anne, when you're managing multiple populations, you mentioned you're moving from fee-for-service into value-based. How does the system not just manage multiple contracts that are value-based, but how does it manage going from fee-for-service to value-based, but doing both at the same time? And Hank, I would imagine that's a struggle for your docs too.
It is a struggle. I'm sure we are. So I think having the data so we can be able to see how we're performing, I truly think we'll always have some type of value-based or some type of fee-for-service contract as a base. Even the capitation that's coming out from CMS, I believe, still you'll be capitated, but that's just on the primary care, is my understanding. So I think that we'll always have something like that. We need to be able to see what areas we need to improve on to be able to achieve that bonus potential. In 2017 data or performance, we were able to distribute over $8 million to our providers based on the performance that we had in 2017. So I think being able to hand out money as a bonus will help drive different performance. And I think having that data ahead of time. So 17, we don't hand out any of that money until the middle of 18. So it's a little bit harder to incentivize performance. But if we can get this data out so the physicians can see how they're doing as we move along, I think that's going to help them keep their eyes on the performance.
No, that makes a lot of sense. One of the questions has been from one of the audience, have you taken on any full risk contracts? You mentioned shared savings, shared risk, performance guarantees. Have you taken on any full risk? And if so, or if you've considered it, what's been your thinking to date about that?
So full risk meaning, if you're meaning global capitation, no. We do have, we are in MSSP track 3, so there's quite a bit of risk there, downside risk. And then we have, I think Dr. Skoski talked about a Medicaid contract that we've had that also has up and downside risk based on a medical loss ratio. So we do have, and fortunately, in the Medicaid that we've had since 2000 or since 1999, we've only had 1 year that we had to pay back. The rest of the time we've achieved bonuses. And then the track 3 ACO for 2017, we did get a bonus for the first time through the MSSP contract.
No, that makes a lot of sense, and it sounds like you are gradually taking on more and more risk, and you're succeeding in that. As you go about taking risk in more highly risk-loaded contracts, what are the kind of things that you think about to evaluate your ability to be successful in that new contract?
Well, I mean, we look at some of the the key drivers of cost, being inpatient utilization, readmissions, ED utilization, which drives all that, and then post-acute utilization. I think those are the big drivers. And so we try and, again, get upstream and identify what are the things that are driving that, and then trying to put our infrastructure around those areas and identify the patients that we can impact. So it's a whole process, really, but it takes data to understand where our opportunities are.
So a couple of years ago, we had a real focus around, I read this book called The One Thing, and there was focus around skilled utilization. Ours was higher than any other ACO. And so we had a real focus around that. So it's looking at that data to helping you determine what do we need to do. We're going to bring the skilled facilities in, we're going to partner with them, we're going to explain, but it's not the easy button. You don't need to go to skilled. Maybe we can keep them one extra day and send them home. So I think looking at data, just helping you decide what areas you focus on.
No, that's great. And so far we've answered questions and thanks to Sean and Rachel and Cynthia and Delana for bringing these kind of questions. It's really awesome. Hank, this one's probably more for you from Julie, is how do you get docs to, utilize these new tools, right? So specifically, like these new techniques, do we do outpatient therapy in the home? Do we do home assessments? Do we, what if a patient's homebound? What about telehealth? What about, are they comfortable with that? Do they think about it? What are the ways that the docs think about sort of these new forms of interventions and treatment?
Well, that's, I don't necessarily know that we push that. We kind of work with our major clinics to kind of let them know what opportunities exist, work with the payers to make sure that there's funding to make these new ways of managing patients viable. And I think most docs there's always going to be a subset of docs that are early adopters, and you just need to identify those and help support those, and then they see success, and it just breeds further success. I think the other part was getting docs to maybe engage with the data. That's an even tougher problem. They're not just sitting around waiting to get into a data system and look around. So you have to be really efficient in getting them the data in a really actionable format, so they can quickly look at what the issues are and understand what they need to do.
That's great. So it truly is a road in progress. People are still adopting, and you're using this decentralized approach to having certain people try new things and then having the others learn from them, see what they're doing, and adapt it. I like it. It's a very democratic process. So I just want to give you kudos, both of you, for joining Dr. Grundy and I, and Hank, it's been really wonderful. You've given some terrific insights for the audience. So thank you very much. I appreciate your joining. I do want to just, before we close today, want to tell you about our next webinar, May 14th, with Dr. Glenn Steele. And we'll be talking about aligning employers. So we've talked a lot about today about CHI Health Partners working with payers, but we're going to talk about aligning employers with this, because they're the folks that are the payers' customers and what their expectations are. Dr. Steele leads the Healthcare Transformation Alliance of some of the top employers in the country and how they're thinking about revolutionizing healthcare. So please come and join us. We're going to send the registration link in your chat box. You can go ahead and register right now in there. But again, thank you again, Ann, Hank, and thank you to the audience for joining us today. We had a great turnout, and we'll look forward to the next time we get together at the next webinar. Thanks, everyone.
Thank you.
Thank you.
With that, that ends our webinar.